Next speaker is Raquel Sánchez Valle.
Buenos días.
Raquel is neurology boss of Hospital Clínic de Barcelona, and she's going to talk about their pioneering programs in genetic dementia.
For the organizers for inviting me for this meeting. It's great to be here in this historical place, but also it's quite difficult to talk after Bruce Miller, so I will try. So this is my disclosures. As you know, familial aggregation is common in dementia, but only a minority of the cases are caused by a concrete genetic defect. Genetic dementia show familial history of disease, most of them with autosomal pattern inheritance, early age of onset in the 30s till early 60s, and clinical phenotypes and neuropathological hallmarks that are quite similar to the sporadic counterparts. Here I will speak about our work in genetic dementias. We will include here as genetic dementias autosomal dominant Alzheimer's disease, genetic frontotemporal dementia, and genetic prion diseases. Many other genetic diseases might develop cognitive deficits in the course of the disease, but have not been included in our series. Autosomal dominant Alzheimer's disease, the most cases are caused by mutations in the presenilin-1 gene, and present a clinical neuropath phenotype that is quite similar to the sporadic Alzheimer's disease with an early onset. Genetic frontotemporal dementias as a group is the more frequent or the frequent type of genetic dementia, but are caused, as Dr. Miller showed before, by several genes. The most frequent is the C9orf72 in the most of the series in the world, followed by the progranulin mutation carriers and the MAP carriers. There are also different variants in different genes that may cause genetic frontotemporal dementia. Each of these genes participates in different biological pathways, and really, for me, there are different diseases, even if they are grouped under the name of frontotemporal dementia. Each gene causes specific clinical and neuropathological features within the FTLD-ELS spectrum. Genetic prion diseases are the less frequent genetic dementias included here, caused by mutations in the prion protein gene, and they present with four main phenotypes: Creutzfeldt-Jakob disease, fatal familial insomnia, Strauss-Schenker, or the phenotype associated with the octapeptide repeat insertion, and these phenotypes are mutation dependent. About 20 years ago, at the Hospital Clínic de Barcelona, we started a program, genetic counseling program for these families, to provide them genetic counseling. It was thought at the beginning as a clinical program to counsel symptomatic patients about his family inheritance in this of dementia, but also to promote informed choices about predictive or symptomatic genetic tests and family planning in at-risk family members. We developed a protocol. Cannot see, I think, the protocol, but it's based on the Huntington disease guidelines for genetic testing that includes pre-test and post-test psychological support. And we found that with this protocol, about 40% of at-risk individuals decide to take the genetic test, and the predictive testing procedure was safe with no major psychiatric events in this population. So far, we have evaluated and included more than 100 families with an identified mutation causing dementia, more than 200 mutation carriers with different mutations, more than 40 autosomal dominant Alzheimer's disease families, 48 genetic frontotemporal dementia families, and 14 genetic prion disease families. We have identified several mutations causing the disease, but we also have identified some clusters of mutations in some parts of Spain. For example, we identified a cluster of this P301L MAP mutation in the Baix Llobregat County in Barcelona in 9 different families that we have studied. All these families share the same haplotype, suggesting that it was really a big family with a founder effect in this region. We also found some changes, some difference from the usually knowledge of the disease. For example, we found this mutation, these two families with, that carry a mutation in the prion protein gene. The prion protein gene are usually thought to be dominant, but we found this in these families that only homozygous carriers develop the disease, while heterozygous carriers didn't develop the disease, at least at till late ages of the disease. You cannot see here, but these were healthy at 80s or 90s, even if they carry the mutation in heterozygous states. In 2009, we start another phase of the program. We start to study genetic dementias in the preclinical and early clinical phases of the disease. We use autosomal dominant dementias as a biological model for the study of neurodegenerative dementias. In the autosomal dominant Alzheimer's disease cohort, we included 65 participants. For asymptomatic mutation carriers, we calculated estimated years from symptom onset as the subject age at the time of the study minus their parental age of onset. We performed clinical and cognitive evaluation, structural and functional MRI, CSF, and serum biomarkers every 2 years, and in a subset, amyloid PET. For example, just an example, we can see in the symptomatic phase of the disease the typical cortical thickness law in symptomatic mutation carriers, but in asymptomatic mutation carriers far from the disease onset, we found increased cortical thickness that we were explained by the increased neuroinflammation in these phases of the disease. We also found different progressive deterioration of the white matter integrity in these subjects. Not only the gray matter is affected in autosomal dominant Alzheimer's disease. And we also found progressive accumulation of amyloid tracer even in very early stages, more than 50 years before the onset of the symptoms in these subjects. And we also found several atypical patterns of amyloid deposition, like this focal amyloid pattern of deposition, this striatal pattern of deposition, of this strange cerebral pattern of amyloid deposition that are not usually in sporadic Alzheimer's disease, but can be seen in autosomal dominant Alzheimer's disease. We also performed several studies with biochemical biomarkers, both in CSF and plasma. For example, we have this study with neurofilament light in serum samples that strongly correlate with the age to the disease onset in mutation carriers, but also with several severity measures like MMSE or CDR, and also to tau markers in CSF. For example, we also have seen that these subjects, even if they are quite young, present also alpha-synuclein in their CSF, 10% of them, in contrast to 40% of the post-mortem studies. So it's quite similar to sporadic Alzheimer's disease markers. We are not the only cohort studying this type of diseases in the world, of course. There are 2 big cohorts in the world. One is the dominant inherited Alzheimer's networks that lead first by Dr. Morris and now by Dr. Bateman at the Washington University in St. Louis. That started in 2009 with just English-speaking countries that has included about 600 participants, and the Colombian cohort led by Dr. Lopera in Medellin, Colombia, that has included about 2,500 100 subjects with the same mutation, the PISA mutation. So with 60 subjects, we thought we cannot compete with this cohort. So in 2009, we joined the DIAN cohort, and we hope we will soon present our own data included in the DIAN cohort. About the genetic frontotemporal dementia cohort, from the beginning we started the cohort within the GENFI cohort, that is the Genetic Frontotemporal Initiative that includes several countries in Europe and in Canada that have included till now about more than 1,000 participants, 60 participants from our side. We have published within this consortium almost 50 papers, but just to, I will underline this paper that was performed in our center. We analyzed 100 progranulin asymptomatic mutation carriers, and we compare these subjects with 96 normal contrasts, and we see that the carriers present an increased cortical thickness low in these lateral, parietal, and temporal areas with age, suggesting that these areas are more vulnerable to the disease in these subjects. We also performed this study that's under the review in C9 or 72 carriers, in which we studied the brain stem white matter low in these subjects. We found that both symptomatic FTD and ELS mutation carriers present lower white matter, increased white matter loss compared to contrast in brainstem, but also in the medulla. Especially in the medulla, there were differences with the ELS phenotype presented more white matter loss than the FTD phenotype, and the FTD phenotype compared to contrast. This is the area where the motor neuron tracts goes down to the spinal cord. So there was identified white matter loss there associated to both phenotypes, but most in the ELS phenotype. And we also, having these subjects, we also can perform more basic of lab studies with these subjects. Familial Alzheimer's disease provides the opportunity to study the subjects before symptoms, but also provide the opportunity to evaluate changes in biological pathways that are minimizing the effect of aging, because these participants are young, they're 30, 40, so we can minimize the effect of aging in these subjects. I'm sorry you cannot see that. There's a lot of results in this figure, but we can see a down regulation of some of the biological pathways related to synaptic signaling, especially in the MAP carriers and the progranulin carriers. But we also were able to identify some changes in some biological pathways, not only in brain, but also in lymphoblastoid cell lines obtained from blood in some of these subjects. This is a pilot study with only 5 subjects per group that has to be validated in bigger samples. Regarding the genetic prion disease cohort, we have also shown brain matter loss in CGD subjects and FFI, fatal familial insomnia patients, and increased indices of the ETI indices in this population. And now we just start a cohort to evaluate clinical cognitive MRI, blood, and CSF markers every 2 years in 50 participants from families with genetic prion disease, thanks to the funds raised by the family of Dr. Baselga, who was a very well-known oncologist that died from Creutzfeldt-Jakob disease last year. But as a clinicians, we cannot stop in observational study. We have to move to interventional study to do drug trials. So we start some trials in our center linked to the DIAN-TU, that is a public-private platform that promotes the clinical trials in autosomal dominant Alzheimer's disease. It's a platform, it's not just a clinical trial, so it's a platform with different arms. They want to try different drugs in this population. And we recently published the results of the first 2 arms of the trial. That's the arms with gantenerumab or solanezumab. The gantenerumab targets amyloid plaques. Solanezumab targets soluble amyloid. The trial, unfortunately, has been negative. We cannot find any difference in, this is placebo in gray, difference the placebo versus the active arms. These are symptomatic, these are asymptomatic, but we also learned that this measure, that it was the primary endpoint, that it was the DIAN composite, cognitive composite, is not well enough because, as you can see here, this composite could not identify decline in the placebo. So even if we cannot identify changes, we cannot also identify changes in the placebo. So it's difficult to know if something happening here or not. Anyway, the gantenerumab shows some effect on biomarkers. Gantenerumab demonstrates changes in the amyloid markers, but it could not become this provide the negativity. They cannot get to the negativity of these markers, but Gante demonstrate an effect on surrogate markers of neurodegeneration outcome markers. Solanezumab could not demonstrate any of this effect. The next steps, we are doing the gantenerumab open-label extension with increased doses of gantenerumab. We are starting the secondary prevention, and we will start soon the primary prevention with an anti-amyloid drug, again, gantenerumab, in participants more than 10 years from symptom onset. This is the design of the secondary prevention trial. This trial will combine anti-amyloid for all the participants with anti-tau that will be randomized against placebo. Both drugs, the anti-amyloid and the anti-tau, are ESI drugs. We are also participating in some clinical trials in genetic frontotemporal dementia. Dr. Mille summarized some of these trials. All these trials have good preclinical data, but some of them have already moved to clinical phases. Phase 1, that's the first phase of the clinical development. Phase 2 and phase 3, that's the phase that the drug may demonstrate clinical effect. We are in a phase 3 with this anti-sortilin antibody. We are in a phase 1 with this intracisterna gene therapy for progranulin. There are other types of gene therapy, also intracisterna magna or intrathalamic, and there are other types of drugs for progranulin mutation carriers like recombinant progranulin, or some drugs that target lysosomal functioning. There are one drug that have been announced a failure for C9 in ELS. This is an antisense oligonucleotide, but there is another antisense that's ongoing in a phase 1 for FTD and ELS, and there is also another trial for C9 FTD ELS with an inverse transcriptase inhibitor. For tau mutations, we learned this morning that there are different potential drugs, but only these Ionis antisense oligonucleotides probably will be tested in MAP mutations carriers soon. For prion diseases, we don't have any trial in genetic prion diseases yet. Recently, the Dr. Med from the UCL announced a failure of their prion protein monoclonal antibody program that did not show any type of efficacy in clinical practice. But Ionis has another antisense oligo that have shown in the preclinical phase an effect on the animal model, increasing the survival time in this animal model. And we hope this molecule will move to a clinical trial soon. In summary, genetic dementia are rare diseases, but they do exist and have additional clinical care needs, mainly genetic counseling program. Genetic dementias provide the opportunity to study a human model of disease with a long pre-symptomatic phase. Biomarkers are needed to track the progression of the disease if there are no symptoms ongoing. Genetic dementias provide a window of opportunity to intervene before relevant neuronal loss. And even if genetic neurodegenerative dementias are rare, effective treatments in these forms could be effective in the most frequent sporadic forms of the disease. So this is our team, this is our funders and our collaborators. Thank you.
Thank you very much, Raquel. Questions for Raquel?
Thank you, Raquel, for this excellent talk and also for your great work in this program. I have a very specific question related to granulin, because as you are part of the work as we are, we have now a hit in granulin in Alzheimer's disease in the very last GWAS. And I wanted to take your opinion on that hit. Do you think we are detecting some kind of co-pathology in the patients, or do you think it's an independent mechanism?
I can hear you very well, but I think you are asking about the progranulin hit in the GWAS. In Alzheimer's, I think, progranulin mutation carriers can be confused as Alzheimer's disease in the clinical. I mean, many of our family members have been diagnosed in previous ages of Alzheimer's, so because the phenotype is sometimes it's not very clear, so especially before the description of the disease. So I think that could be something. There has been quite a lot of work about progranulin levels in Alzheimer's disease, and it's not clear the effect of progranulin, the protein, in Alzheimer's disease. So I'm not sure if it's relevant. Of course, progranulin is a survival protein, so I'm sorry, I have no a real answer. It can be several. May have some explanations because progranulin mutation card could be included in the series, but of course, progranulin is a survival protein, in addition to be included in some lysosomal storage pathways, so that are not very far from the Alzheimer's disease neuropathology. So I think that I have no a clear answer to your questions.
Questions? I have a question myself. I'm looking at the tables of your presentation and also Dr. Miller. We see that from the temporal dementia, we have a lot of genetic treatments, not for Alzheimer's disease. Do you think this is more because it's more complicated in the case of these mutations, or because the pharmas are focusing more on anti-amyloid, anti-tau? What is your opinion?
There is
more genetic treatments for frontotemporal dementia, but not for Alzheimer's disease.
I think it's maybe that's there are. Genetic frontotemporal dementia are different diseases. Yeah? For me, there are different mutations. There are different diseases. There are different mechanism of disease. The progranulin mutation is an exception in the neurodegenerative field because it's a reduction. It's not an increase of function, but it's a reduction that could be theoretically more easily to be manipulated, so there are more potential drugs that could be tested in this population. But I think that the fact that now we are having much more trials for FTD than for genetic Alzheimer's disease is not due to the lack of interest of the pharma companies on the Alzheimer's disease field, but I think it's due to the fact that it's controlled centrally from the platform. So on the platform, the INTU platform is controlling which drug is coming to the clinical trial, not each pharma company that could be interested in the field can enter this population. That's different from the genetic frontotemporal dementia, that there is no central platform, a general platform, and each drug company contacts with the researchers.
Okay, thank you very much.